Assalamu alaikum. Hope you guys are fine. Today's our lecture is on the, as you all know, that occlusion. It will be continue in a series of the previous occlusion lecture. Today's lecture is on its second part, which will be given by Dr. Naghman Zuberi. Assalamu alaikum, sir. Hope you are fine.
Alhamdulillah, walaikum assalam. I am good. What about you?
Sir, alhamdulillah, I am also good. Sir, you can continue with today's lecture.
Okay, thank you. Good morning. Assalamu alaikum, everyone. So, today we are continuing our talk in context to our previous lecture on occlusion. And as I promised you, that today we will be discussing the 6 keys of occlusion, and then we will be discussing the organization of occlusion. So let's start with the Andrews 6 keys to normal occlusion. Andrews is the same person who gave the concept of a straight arch technique or straight arch wire technique in orthodontics, where he built the angulations and all the movements within the brackets. And if you place the brackets at the right place on the tooth, just using the straight arch wire, the movements are going to start occurring. So that was the concept behind Andrews' all studies. He gathered data from 1960 to 1964. He gathered the data of non-orthodontic normal models. Means those models which he selected, they never had any orthodontic treatment. Teeth were straight and pleasing in appearance. They had a bite which looked generally correct and would not be benefited from orthodontic treatment. Means whatever is looking nice, even if you try to do some refinement using orthodontic treatment, so there won't be any further benefit they will achieve from the orthodontic treatment. So he studied occlusion using those models for 4 years. And he brought forward 6 keys to normal occlusion. Key 1 says about the molar inter-arch relationship. He actually refined the class 1 molar relationship, which was given, that concept was given by Edward Engel. So he refined that concept. How? I will just let you know. Key 2 is about the mesiodistal crown angulation. Key 3 was about the labiolingual crown inclination. Key 4 says that in a normal occlusion, there must not be any rotation. And key 5 says the contacts should be tight, not too tight, but tight, adequate, so that the interdental papillae are going to be supported. And key 6 was about the curve of speed, that it should not be very accentuated, it should not be very deep, as we see in class 2 malocclusions. So firstly, the key 1, molar inter-arch relationship. The mesiobuccal cusp of the upper first permanent molar, it falls within the groove between the mesial and medial cusp of the lower first permanent molar. We know this from Edward Engel's explanation of class 1 molar relationship. Now, question occurs, what happens to the mesiolingual cusp? Edward Engel never told us what is happening. Just he told us about the mesiobuccal cusp. What is happening with the mesiolingual cusp? According to Andrew, the mesiolingual cusp of the upper first molar seats in the central fossa of the lower first molar. Then we will consider it as a normal occlusion. Now, if we just look at these 2 points, it means that the molar is, upper first permanent molar is very straight. It is like at 90 degree. That is not true. The crown is angulated. The crown of the upper first molar must be angulated so that the distal marginal ridge occludes with the mesial marginal ridge of the lower second molar. So basically, upper first permanent molar is coming in two teeth relationship. Its mesial portion is occluding with the lower first permanent molar, and distal marginal ridge is occluding with the mesial marginal ridge of the lower second molar. This is how it is angulated. This is how the first permanent molar's mesiobuccal cusp is articulating into the buccal groove of the lower first permanent molar. But it is not straight. It is never straight. It is at an angulation in such a way that the distal marginal ridge of the upper first permanent molar should articulate with the mesial marginal ridge of the lower second molar. Then the mesiodistal crown angulation. The second key makes use of a line that passes along the long axis of the crown through the most prominent part in the center of the labial or buccal surface. This line is called the long axis of the clinical crown. Every single crown has a different angulation. Say, for instance, the central incisor. It is never at 90 degree. When we look at the long axis of the tooth, it is at an angulation with the vertical. So, considering the occlusion as normal, the gingival part of the long axis of the crown should be distal as compared to the incisal or occlusal part. It should be distally inclined. Or you can say that the mesial part should be inclined, the incisal part should be slightly mesially inclined as compared to the gingival part. You can see it even in the natural dentition of a normal occlusion. When we look at the long axis of the tooth, the long axis in such a way that the gingival part is slightly distal to the incisal part. Different teeth, they have different angulation. Like the central incisor upper, it is at 5 degrees from the vertical. Now look at all the centrals and laterals maxillary. You can see that they have slight mesial angulation. And if you remember, while you were doing your setup of the dentures, the teeth you always set in such a way that the gingival part is always at a distal inclination and the incisal part is always at a mesial inclination or mesial angulation. So this is the second key of normal occlusion. Teeth should be angulated in such a way that the gingival part should be slightly distal as compared to the incisal or occlusal part. Key number 3, labiolingual crown inclination. The crown inclination is determined from a mesial or the distal view. If the gingival area of the crown is more lingually placed than the occlusal area, it is referred to as positive crown inclination, like your central incisors, maxillary, and lateral incisors. They are slightly in proclination, and we call it that they are in positive inclination. In case the gingival area of the crown is more labially or buccally placed as compared to the occlusal or incisal surface, then it will be called negative crown inclination. When we look at a normal occlusion, a model of normal occlusion, or a person who has normal occlusion, so what happens actually? Only maxillary incisors, they are in positive inclination. Rest of the teeth, they are in negative crown inclination. Means when we look, see it from the proximal side, either mesial side or from the distal side, teeth are in negative inclination other than maxillary incisors. All other teeth should be, for an ideal occlusion, they should be in negative inclination. You can see it over here. Even lower incisor is in negative inclination. Well, some of the authors, they say that there is not even any inclination of the mandibular central, like all the incisors, four incisors, they are not in any inclination. They say that they have zero inclination. But according to Andrew, they are in -1 degree negative inclination. Posterior crowns are also negatively inclined. Key number 4, absence of rotation. Normal occlusion is characterized by absence of any rotation. Rotated posterior teeth occupy more space in the dental arch, while rotated incisors, they occupy less space in the arch. How? Check out this case. Now, why rotated uh, posterior teeth, they occupy more space in the arch? Because of their buccolingual width. Their buccolingual width is too big, too large as compared to their mesiodistal width. So when they are rotated, they occupy more space in the arch as compared to anterior teeth. When they are rotated, because of their labial lingual width, it is quite thin. So when they are rotated, they occupy less space in the arch. In order to straighten those, you need more space. And when you are rotating this tooth, you will be gaining some space. You will be having some space available. Key number 5 says there should be tight proximal contacts in order to have very good health of the interdental papillae. Once the interdental papillae, they have good health, then the underlying bone is also healthy. Whereas if the teeth, they have open contacts, then the interdental papillae, they will become flat, and because of that, the underlying bone is also not very healthy. Key number 6 says about the curve of spee. Usually, the depth of curve of spee ranges from flat plane to slight concave surface, 0 to 2.5 millimeter. In class 2 div 2 cases, we have very deep curve of spee. And when we discuss about the treatment objectives of class 2 malocclusion, we always say one of the objective is to flatten the curve of spee. So our aim is to achieve the flat curve of spee, though up to 2.5 millimeter is considered as normal. But keep in mind, there is a natural tendency for the curve of spee to deepen as the age advances, and there would be chances of relapse as well. This is the flat curve of spee. Another very important thing is when you flatten the curve of spee, you gain the space. This is the accentuated curve of spee. There will be crowding in this case. Now, we will discuss about the organization of occlusion. I have earlier in my previous lecture mentioned that there are 3 recognized concepts that describe how teeth should contact in various mandibular positions. One is bilateral balanced occlusion. That is true for complete dentures and very long span partial dentures, removable partial dentures. Unilateral balanced occlusion, though you can have it in natural dentition, but usually we bring that unilateral balanced occlusion in bridges, in fixed prosthesis, in order, especially if they are present in the uh, they are involving the canine and premolar region. Then comes the mutually protected occlusion or canine protected. This is an ideal form of occlusion in natural dentition. So let's see. This is a denture in centric. Even in protrusive, all the teeth are in contact. When we go for the bilateral balanced occlusion in complete dentures, the transition from the centric or rest position to the protrusive, it should be without any interruption and without disengaging any tooth. It should be very smooth, a cyclic movement, very smooth movement. There must not be any separation of the teeth. If there would be any separation in the posterior region, like in the natural dentition, what is going to happen? The dentures, using this as a pivotal point in the protrusive, they will get dislodged. We don't want it. For their stability, we need balanced articulation or balanced occlusion. Similarly, in case of laterotrusive, when there is working side, the working side will be having all the teeth in contact. Similarly, balancing teeth, they will also be on contact. The balancing side will be in contact so that there won't be any rotation and dislodgement of the denture because of using the working side as a pivotal point, and there will be instability. In order to have stability, to achieve stability, to have normal chewing movement without any interruption, we need bilateral balanced occlusion. Unilateral balanced occlusion or group function. As I told you, if you are giving bridges or if you have any other problems where you cannot give canine guided relationship, even in the natural dentition, so what we do, we go for the group function, which is only posterior teeth on the working side, they will be in contact, and rest of the dentition will be out of occlusion. That is called unilateral balanced occlusion or group function. Balancing side teeth must not come in contact in case of group function. Then comes the mutually protected occlusion or canine protected occlusion. Let's see what is this canine protected occlusion. Anterior teeth, they overlap and prevent the posterior teeth from making any contact on either the working or non-working sides during the edge to edge or mandibular excursion position. Anterior teeth bear all the load and the posterior teeth are disoccluded during excursive movements, protecting the posterior teeth from any interference and occlusal trauma. In case of centric occlusion, only the posterior teeth, they are having contact and they direct forces through their long axis, and the anterior teeth are slightly in or out of contact. Either they are in contact, but they are not having any stress on those, or in some of the cases they are out of contact, so anterior teeth are protected. That's how in canine guided occlusion, posterior teeth and anterior teeth, they mutually protect each other. In protrusive, the anterior teeth are protecting the posterior teeth, and in centric occlusion, posterior teeth are protecting the anterior teeth. So over here, we are done with our second lecture on it, and next time we will be discussing about the 3-point contact, if possible or not, or if not possible, then how we can achieve a 2-point contact so that the forces will be directed along the long axis of the teeth, and how we can prevent the occlusal trauma. What would be the sequelae of occlusal trauma if off-axial forces are hitting the teeth? So see you inshallah next Monday with the new lecture, and till then, thank you very much. Goodbye. I ask Farooq to take over.
Thanks a lot, sir, for today's great lecture. Sir, also, sir, let me tell you and all the audience here that inshallah we are having on 14th of August on Friday. We will be having a lecture by at 7 p.m. Pakistan time and 10 a.m. I guess Eastern time in the
10
calendar.
a.m. Yes, 10 a.m. Eastern Time.
Yes, sir. Sir, 1 minute. I let me share one of your banners so that everyone can know about it. The lecture, or if it will be added in the if you go to the YouTube channel, you will, or Facebook our page, you will be get is the information about it. It's a lecture on the proximal caries and fluorides. So see you inshallah on the Friday in Azadi virtual Azadi special virtual conference. Thanks a lot, sir,
Thank
for
you very
today's
much.
lecture.
Thank you, everyone,
Inshallah.
for listening.
uh,
And
okay, sir.
any
Khuda Hafiz, sir.
questions, there you will send it to me. Thank you.
Khuda Hafiz.